Hello everyone, this is Dr.Bibaswan from Department of Biochemistry, SIM Shimoga, Karnataka. So as requested by some of the first MBBS students for the upcoming biochemistry practicals, we have intended to make a short video for the case-based questions. So we'll just cover the key points of each question. The first 4 to 5 questions are on jaundice. Simple thing, if all the parameters are in the normal range, then it's a normal report. If only conjugated bilirubin is increased together with marked ALP increase and urinary bile salts and bile pigments positive, then it is post-hepatic or obstructive jaundice. If only unconjugated bilirubin is increased, AST, ALT not much change, and if there is a history of pallor, splenomegaly, hemolysis, then it is prehepatic or hemolytic jaundice. If both conjugated and unconjugated bilirubin levels are increased and AST and ALT levels are also increased, these four mainly. So if your AST, ALT are in the range of 250, 300 like that, and your both conjugated and unconjugated both are increased, then you have hepatic jaundice. Then for the physiological jaundice of newborn, it is simple. There will be a history of newborn baby 2 days old, 3 days old. There will be a history of the high unconjugated bilirubin. The high unconjugated bilirubin. And the baby is advised phototherapy. That's a clue. And the baby will be having jaundice, icterus. So if this combination is there, then it is physiological jaundice of newborn, which is in fact hemolytic jaundice is happening here. Then one more special type of jaundice is there. That is glucose 6-phosphate dehydrogenase enzyme is deficient, so we are having hemolytic jaundice over there. So there, what are the special points? There will be a history of fever, shivering, and there will be this history of primaquine, anti-malarial drug primaquine. So after taking primaquine, the condition will become aggravated. And also you will find the Heinz bodies. Microscopic examination of the RBCs will show Heinz bodies. These two are very, very characteristic to diagnose here glucose 6-phosphate dehydrogenase enzyme deficiency induced hemolytic jaundice. Special type of jaundice, mind you. This SPD is a special type. Then cirrhosis of liver, one case is there. Cirrhosis of liver, how to diagnose? First of all, you will have the history of the patient might be the alcoholic, male patient, might be complaining of vomiting of blood, that is hematemesis. The serum albumin levels may be low. There might be hepatomegaly, that is increased liver size, that is liver enlargement, and also there will be elevated gamma glutamyl transferase GGT or gamma GT. That level may be increased. This picture is very characteristic of alcoholic liver cirrhosis. Then there was a case on acute pancreatitis. In acute pancreatitis, it is very simple. Look for elevated amylase and elevated lipase. If this is there, instantly you can see acute pancreatitis. Then there were some cases on kidney kidney failure, nephritis and all were there. Simple. If urea, creatinine and uric acid levels are increased, and if the patient is complaining of edema of face, oliguria, that means less passage of urine, less than 400 ml in past 24 hours. Then if the patient is complaining of confusion, also if the pH is dropping below normal, if you see acidosis, like pH is becoming like 6.8, 7, like that, very low pH, and the phosphate levels are increased, the potassium levels are increased, the calcium levels are decreased, serum levels, I mean, all these. So in this picture you can say it's a case of renal failure. Then there is a case on nephritis. Nephritis, what is the speciality? Nephritis, the speciality is you might be having facial edema, you might be having oliguria, but in nephritis you will have RBC cast positive, RBC cast positive. So if you see RBC cast positive, you can say it is nephritis. This RBC cast positive will usually not be there in the renal failure. So if you see like the facial edema and oliguria and certain other like derangements, let's say GFR is decreased and all that is fine. But if you see this picture together with RBC cast positive, then you can say it is nephritis. Nephritis, acute glomerulonephritis, whatever you want to say. Then there were some cases on nephrotic syndrome. Nephrotic syndrome has a very characteristic presentation. So what is it? Hypercholesterolemia, hypoalbuminemia, hyperproteinuria. Listen to it. Hypercholesterolemia means increased serum cholesterol. Hypoalbuminemia, which means decreased serum albumin, and hyperproteinuria, which means proteins are coming out in the urine. If these 3 points are there together, you can say directly that it is nephrotic syndrome. Nephrotic syndrome usually occurs in children, but there are cases where it has been found in the adults also. So don't go by that only, go by the 3 parameters I said: hypercholesterolemia, hypoalbuminemia and hyperproteinuria. Then what case was there? Then there were some cases on diabetes and glucose tolerance and all. So if you are doing an OGTT, which is an oral glucose tolerance test, if you are taking 5 samples and in all 5 samples the urine sugar comes out to be nil, all 5 samples, fasting sample, half an hour, 1 hour, 1.5 hours, 2 hours, all 5 samples your urine sugar is nil, you can tell that this is normal report. The oral glucose tolerance test is normal. If you are doing oral glucose tolerance test and your urine sugar is coming positive in 1 or more of the samples, that too, let's say after half an hour your blood glucose is 120, but your urine sugar is coming positive. After 1 hour it is 150, but your urine sugar is coming positive. Then it is impaired. Like the oral glucose tolerance test is impaired, it is abnormal. Because as we know, renal threshold of glucose is 180 milligram per deciliter. So until the glucose reaches 180, you should not be getting sugar in the urine. But if you get it below 180, that means that this report is abnormal. The oral glucose tolerance test OGTT is abnormal. Then there were some cases on diabetes mellitus and diabetic ketoacidosis. These are very characteristic. Diabetes mellitus, what do you look for? Polyphagia, polydipsia, polyuria, pruritus, and peripheral neuropathy. That's a characteristic pentat. So even if all are not there, if you have like increased frequency of micturition, that means polyuria. If you have increased thirst, that means polydipsia. If you have increased appetite, that means polyphagia. Here only this itself is a clue that this case is diabetes mellitus. On top of that, you do the lab reports and you see that fasting blood sugar is say 190, postprandial blood sugar is say 240, urine sugar is also positive. If you get all these findings together, you can say that it is a case of diabetes mellitus, because symptoms and the blood reports. WHO has this criteria for diagnosing diabetes mellitus. The same in WHO and in the ADA, the American Diabetic Association. If your fasting blood glucose is more than equal to 126, if your postprandial blood glucose is more than equal to 200, and if your HbA1c is more than equal to 6.5%. If these three are there, then we can say that it is diabetes mellitus. These cutoffs are asked very commonly in the exams. Then, what about diabetic ketoacidosis? So the patient is of diabetes mellitus only, but with certain additional findings. So what findings? Findings like semi-conscious state, low pH, fruity odor from breath. That is the Kussmaul's breathing, due to the presence of the acetone in the breath. The ketone body acetone comes out. Plus also urine ketone bodies are positive. If these are there, plus the usual diabetes mellitus findings of high blood glucose and urine sugar positive, whatever. If this is the picture, then you can tell it is diabetic ketoacidosis. Note the difference between diabetes mellitus and diabetic ketoacidosis. It is actually pretty simple to make out the difference. Then there was a case on starvation ketoacidosis. How do we say starvation ketoacidosis? Starvation ketoacidosis is when maybe the pH is low, maybe the person comes in semi-conscious state, but the blood glucose level has dropped. If the pH is low and the person is unconscious and the blood glucose level is 580, then it is diabetic ketoacidosis. But if the pH is low and the person is unconscious or is semi-conscious and the blood glucose level is 40 or 50, then it is starvation ketoacidosis. It is pretty easy to make out the difference. And there was one case on myocardial infarction, if I am right. Myocardial infarction, simple. You will have these biomarkers. The biomarkers will be elevated. So, there is this very classical description. Obese person complaining of shortness of breath, chest pain, edeno, and blood reports are showing increased creatine kinase, lactate dehydrogenase, and AST, aspartate transaminase. This much if you see, it's enough. You know. Actually, the moment you see obese with complaint of shortness of breath and chest pain, that itself is your first clue. This is myocardial infarction. Myocardial infarction. And what all are the usual parameters we see? For blood parameters, as we said, creatinine kinase, aspartate transaminase, lactate dehydrogenase. Also, so within creatine kinase, which is the most specific, CKMB. CKMB is one of the isoenzymes of creatine kinase, which is very, very specific for myocardial infarction. You see it. Also, we do troponins also. We check for troponins, troponin I. That test is also done. And we also do ECG. Usually, we do an ECG on spot and we check the ECG in conjunction with these blood biomarkers, which I just mentioned, creatine kinase, etc. These are the first 20 cases. Hope that helped. Thank you. We'll be coming up with the video of the next 20 cases soon. Stay tuned.